Welcome to this explainer. Today, we're unpacking some truly fascinating research that completely flips the script on how we think about aging and healthcare access. We're diving into a breakthrough study that takes the theories of a legendary French sociologist and applies them directly to modern European health data. It's a totally fresh perspective, uncovering the invisible forces that dictate our health in later life.
So picture this. If I asked you right now to guess why some older adults are at the doctor regularly, staying healthy, while others only show up for frequent, lengthy hospital stays, what would you say? You'd probably think, well, it's just money, right? If you can afford care, you get care. But the evidence actually reveals a much more complex and, honestly, a much more interesting reality. Wealth is really just one piece of a much larger puzzle. Traditional ways of measuring socioeconomic status via income, education, and occupation are even more problematic once people retire. Researchers are finding that looking solely at a person's bank account or their old job title simply doesn't give us the full picture of their health habits. Think about it. When people retire, their income drops and their occupation is totally in the rearview mirror. Relying on those traditional metrics leaves a massive blind spot when we're trying to figure out why health inequalities persist among older populations.
Here is our roadmap for today. 1. The healthcare inequality puzzle. 2. Bourdieu's three capitals. 3. The European health data. 4. The power of capital structure. And 5. Beyond just money. Let's jump right in.
Section 1. The healthcare inequality puzzle.
Unequal access for equal need. Income alone cannot explain why older adults utilize healthcare so differently. Here is the puzzle that's been keeping policymakers up at night. In theory, we should see what experts call horizontal equity, which is just a fancy way of saying equal access for equal need. If two older adults have the exact same medical issues, they should theoretically use health services equally. Yet, across Europe, even in places with universal healthcare, we see persistent socioeconomic inequalities. This proves that money is absolutely not the only barrier here. Something else is keeping people out of the waiting room.
Section 2. Bourdieu's three capitals. Habitus, an embodiment of the social and material conditions in which people live, which generate distinctive tastes, preferences, and lifestyles. To solve this healthcare puzzle, researchers turn to the renowned sociologist Pierre Bourdieu and his concept of multiple capitals. He coined this term, habitus, which is basically the embodiment of our social and material conditions. The absolutely crucial takeaway here is that our upbringing, our education, our environment, they literally become hardwired into our everyday habits, including our health practices. It's not just about what you know, it's about what instinctively feels natural to you.
Economic capital involves money, property, and financial assets. Cultural capital is your individual skills, health literacy, and behaviors. Social capital is a durable network of relationships for support and information. Bourdieu argued that we actually navigate society using these three main forms of capital. First up is economic capital. That's the obvious one, right? Second is cultural capital. In the healthcare world, this translates to your personal skills, your health literacy, and your learned behaviors, like can you confidently chat with a doctor and actually understand all those complex medical terms? And finally, social capital. This is your network. Do you have friends or family pushing you to go to the clinic when you're feeling off? Think of these three capitals as a backpack of resources you carry with you through life. Your social network and cultural knowledge are quite literally just as valuable as your wallet.
Measuring cultural capital. 1. Institutional state. 2. Embodied state. 3. Objectified state. But how in the world do we actually measure something as invisible as cultural capital? Well, researchers look at three states. The institutional state is just your highest degree. The embodied state looks at your parents' education level, essentially the vibe of the environment you were raised in. But look at number 3, the objectified state. This is wild. Researchers can actually measure your cultural capital today by looking back at the number of books in your childhood home at age 10. Having a house packed with books as a kid turns out to be a massive indicator of the cultural health capital you carry well into your 60s and 70s.
Section 3. The European health data.
Shared dataset demographics for adults aged 50 and up, female at 54.7% and male at 45.3%. Now that we have our toolkit, let's see this theory in action using the Survey of Health, Aging and Retirement in Europe, also known as the Shared Dataset. This is a massive dataset tracking nearly 65,000 older adults across 15 European countries. It gives us an incredible window into real human behavior, tracking everything from their wealth to their social lives, all the way to how many times they visited the hospital.
26%. So, what did the data reveal? Well, unsurprisingly,
Older adults with high economic capital have 26% higher odds of seeing a doctor. Money definitely matters. It buys you a house in a healthier neighborhood, supplementary insurance, and an easy ride to the clinic. But the researchers found that wealth was literally just the beginning of the story. Cultural and social capitals prove to be wildly powerful, independent predictors of how people use healthcare.
Section 4. The power of capital structure.
Capital structure comparing economic capital and sociocultural capital. This is where things get really fascinating. When researchers mixed and matched these resources, they unlocked the ultimate predictors of health. They grouped people into 4 unique capital structures by rolling social and cultural capital into one big bucket called sociocultural capital, and then matched it against economic capital. So you end up with a high-high group, a low-low group, and the 2 mixed groups. By analyzing these specific combinations, they discovered that having strong non-material resources can actually compensate for a lack of cash.
Increased odds of dentist visits compared to the low/low baseline. High economic and high sociocultural is at 3.26x. Low economic and high sociocultural is at 1.91x. High economic and low sociocultural is at 1.76x. Let's look at dentist visits. The high group goes over 3 times as often as the baseline. But check this out. People with low wealth but high sociocultural capital go to the dentist almost twice as often as the baseline. That is actually more frequently than wealthy people who lack those cultural and social connections. Let that sink in for a second. Your community ties and health literacy can actually drive you to seek preventative care more effectively than just having a huge bank account.
Choice of necessity versus freedom of choice. This whole dynamic perfectly illustrates Bourdieu's concept here. Folks with low capitals generally only use healthcare for immediate emergencies out of absolute necessity. They're going to the hospital when the pain is unbearable. Meanwhile, those with higher capitals, especially that higher sociocultural capital, they use services strategically. They go get a routine dental cleaning. They see the doctor for a basic checkup. They have the freedom of choice to play the long game with their health, preventing those massive, costly hospital stays down the road.
Section 5. Beyond just money.
Traditional view. Health access is purely income-based and fixed by financial aid. Versus Bourdieusian view. Health access is capital-based, requiring interventions that build social networks and health literacy. As you can imagine, these findings have massive implications for our aging populations. The traditional view says, hey, if people aren't going to the doctor, we just need to give them financial aid. But the Bourdieusian view proves that health access is capital-based. We've got to shift from simply throwing money at the problem to actively helping older adults build community connections, level up their health literacy, and gain the confidence to navigate these complex health systems. A subsidy won't do a thing if someone doesn't have the social encouragement or the practical know-how to actually book the appointment.
How are your own social networks and cultural habits shaping your future health? As we wrap up this explainer, it definitely leaves us all wondering what's currently sitting in our own backpack of resources. Because it turns out, it is not just about saving for retirement financially. It is absolutely crucial to invest in your social circles, keep reading, keep learning, and cultivate habits that are going to protect you decades from now. So how can you start building a richer capital structure today? Take stock of your invisible currencies. Thanks for joining me on this deep dive.